Hello, everyone, and welcome to another episode of Dr. Krob's Headache Vlog. I'm Dr. Alexander Krob, headache expert, and today's video is another in the series on headache pattern recognition. Now, this series is primarily designed for healthcare providers in primary care, nurse practitioners, physician assistants, clinical researchers, and it's designed to help them hone their skills on headache diagnosis so that they can get the right diagnosis and get the right treatment to help someone living with headache. Now, if you're a person living with headache, this video is also for you because it will help you communicate better with your provider, and better communication is going to lead to better outcomes. The design of all of these videos is we're going to take an idealized patient case that's been assembled from patients that we see in the clinic to represent ideal patient with a typical headache diagnosis. And we're going to present that patient, and then we're going to talk about diagnostic criteria, and then simple pattern recognition that is easy to apply in a clinical setting and will probably get you to a diagnosis and therefore to a treatment really quickly. So let's get started with the case of Lee here. And Lee is a 32-year-old man who's seeing us for frequent headaches. His headaches started in high school, and they've become more frequent in college. For the past several years, he has a headache every 2 or 3 days, except when he's on vacation. His typical attacks are diffuse, all over his head, they're dull pain. He says he grabs a bottle of water, takes some aspirin, and grabs something to eat. He says if he's at work or coaching his kids' soccer, he just keeps going. The headaches can last for a couple of hours or a couple of days. And he says that he and his wife, he really didn't want to come, but he was talking to a friend who said that his brother had headaches before he was diagnosed with a brain tumor. So his medical, family, and social history really indicate a guy who rarely goes to the doctor. The last time was 3 years ago for a jock itch problem. He's a non-smoker. On review of systems, which is that big sheet of questions that doctors give you before your appointment, he circled neck and shoulder pain, and he's had this chronic mild left ear hearing loss since high school. He has no known drug allergies. He really only takes a Benadryl every once in a while for insomnia. His vital signs look a lot like mine. He's sort of a little high on the blood pressure scale. He's got a good pulse. His BMI is on the obese range, above 30. In general, he looks like he's kind of an aging jock, that sort of muscular but kind of well-padded body shape. And then his Mallampati score is 3, and a lot of you will be wondering, what is a Mallampati score? And it kind of is this. It's when you look down his throat using the little light, you basically almost don't see the little dangly thing called his uvula, and it's sort of hard to see how the air is going down there. Now, a Mallampati score of 3 starts to place Lee at reasonably high risk for obstructive sleep apnea. And obstructive sleep apnea is important to identify in a patient with headache because it's kind of an easy fix. On his neuro exam, he's got trace reflexes, again, not abnormal, and an absent Babinski sign. He's never had any kind of brain imaging, which is one of the reasons why he's there to see you. He's never had any labs, or recent labs. He did have an EKG done in 2013 for an atypical chest pain episode that was normal and showed normal sinus rhythm. So everyone, what's the diagnosis in this case, in Lee's case? And I'll give you just a few seconds to think about one. Options could include things like migraine, cluster headache, tension headache, medication overuse headache, or maybe Lee has a brain tumor. What do you think? Okay, here's my answer. I'm pretty sure that Lee has frequent episodic tension type headache. Now, this is ICHD number 2.2, ICD-10, G44.209. The official ICHD-3 diagnostic criteria include at least 10 episodes of headache occurring 1 to 14 days per month on average for more than 3 months, and between 12 and 180 days per year of attacks. They fulfill the following criteria. They can be lasting as short as 30 minutes or up to 7 days. They have at least 2 of the following 4 characteristics. They're bilateral, they're pressing or tightening, they're mild or moderate, never severe. They're not aggravated by routine physical activity such as walking or climbing. And there you go, Lee just plays right through his kids' soccer games. both of the following. There's no nausea or vomiting. And remember that Lee says that when he gets a headache, he can still eat. He actually, that's one of his preferred headache treatments. He eats a little bit, has a little bit of caffeine, and then pops some pills. There's no more than one of photophobia or phonophobia. Again, he's out on a bright soccer field with lots of screaming kids. He's not being put down by those symptoms. And again, there's always this catch-all phrase at the end of every ICHD-3 diagnosis that says not better accounted for by another diagnosis. And that is a reminder to consider all other options, including secondary and symptomatic headaches. So remember that the International Classification of Headache Disorders, Volume 3, ICHD-3 criteria are really for research purposes. In a clinical setting, you can still use them, especially if you're adept at it, but they can kind of be cumbersome and difficult. So for this type of headache, for Lee's type of headache, I think the pattern to recognize is the not, no, non pattern. In other words, they are non-throbbing. There is no disability. There is not any photophobia. There is not vomiting. They're non-specific headaches. Now, I will say, as a caveat, that because they are non-specific headaches, I am going to be very careful in screening for secondary and symptomatic headaches in Lee's case. I'm going to scrub his chart for any evidence of old imaging. I am going to do a very thorough neurologic examination looking for any signs of neurologic problem. And even after all that's done, I am still going to be thinking about doing an appropriate imaging study like an MRI of the brain without contrast in order to look for potential secondary or symptomatic headache causes. Now, an MRI in Lee's case is almost certainly going to be non-diagnostic, although there are going to be some minor imperfections on his MRI, and it is the job of a knowledgeable clinician to identify those imperfections and determine if they're clinically significant, in which case I would call them an abnormality, or whether they're not clinically significant, in which case I would call them an incidental finding. And what sort of things might you see? You might see some of those non-specific T2 white matter abnormalities. Those are of increased frequency in people with any kind of headache. You might see a few minor structural abnormalities, including some small arachnoid cysts or pineal cysts, possibly even a tendency towards low-lying cerebellar tonsils or a Chiari malformation. Those are in general very unlikely to be highly contributory to this headache problem. And pursuing those sorts of things via surgical approach, I think, is a bad idea before you try non-medicinal and medicinal approaches in helping Lee with his headaches. So I would say that the approach to Lee's headache problem could include both non-pharmacological and pharmacological treatments. Non-pharmacological treatments, I think, are probably long-term more sustainable and more effective, although they do require more time and more effort. They include things like time management. Why is that important? Well, I think Lee is like any typical parent. He's got time in his life for 5 top priorities, and his own health, his own self-care is probably priority number 6. And that's why you get surrogate markers like obesity and hypertension. I mean, Lee is not obese because he's a glutton or because he's lazy. Lee is obese because in his day, he has time to coach the kids' soccer, he has time to do stuff around the house, he has time to go to work, but he really has cut his time management to the bone where his self-care time, in other words, time to eat his lunch wisely and moderately, time for exercise, time for relaxation is really, there's no room in his time management schedule. I think the other thing that we would work on with Lee is possibly some relaxation techniques. He had an episode of non-cardiac chest pain several years ago, and I think most of us recognize that non-cardiac chest pain episodes are frequently related to anxiety. He also takes a sleep aid some nights, probably more nights than he reports again, so poor initiation of sleep is also sort of anxiety related, so relaxation techniques could be very important for him. It's important to look at his sleep hygiene because, as I said, he does have a Mallampati 3 airway. Sleep hygiene is also quite frequently poor in weekend warrior types. Then, of course, there's manual therapies like massage or acupuncture, even chiropractic, provided it doesn't involve any abrupt neck manipulations. And then there are devices such as the one that are depicted here, like EMG biofeedback. And, there are some people who really do like their wearable technology, and this is one example of wearable technology that can be applied to people with a headache diagnosis. Now, there's also the pharmacologic treatment strategies, and they include things like simple analgesics, so over-the-counter medications and concoctions like Excedrin or NSAIDs or aspirin or Tylenol, acetaminophen, and those are reasonable to use provided that the frequency of use probably doesn't exceed 2 or 3 times a week, and in Lee's case, he's really pushing that limit. And then, of course, the other standby for people with tension-type headache is a tricyclic antidepressant like amitriptyline, nortriptyline, protriptyline, which could be a good fit for Lee because he already has some sleep initiation problems. The only reason that it might be a bad fit for him is because tricyclic antidepressants are somewhat associated with weight gain. Now, in my practice, I do find that the weight gain is less of a risk than people initially anticipate, and typically the reason for that is that when a headache prevention treatment works, you lift the burden of headache from someone's shoulders, and they become much more active. They become much more proactive about the things that they choose to eat. They become much more proactive about initiating exercise programs, and so I think that the weight gain risks of tricyclic antidepressants in people with a frequent headache diagnosis are somewhat overplayed. So I think in his case, if we were going to choose a pharmacologic treatment, I think a tricyclic antidepressant could certainly be helpful. So I wanted to thank everybody for watching this episode of Dr. Krob's Headache Vlog. If you did find this information useful and entertaining, please give me a like. Please use the button somewhere on this screen to subscribe, and then I will post a list of other helpful videos. One last thing, which is please remember that the content of my videos is for education and information purposes only. If you need medical advice, please, please, please see your healthcare provider. Thank you for watching this episode of Dr. Krob's Headache Vlog. I'm Dr. Alexander Krob. I'll see you later.